Hi, this is Jamie Hadfield with Legends Health, Wellness, and Performance, and today we have a special guest. His name is Ethan Carruthers. He is a doctor in pharmacy, and he has been practicing in the field of medical cannabis, and he's been getting people to a therapeutic endpoint in helping a lot of individuals in Minnesota. Welcome, Ethan.
Thank you very much for having me, Jamie. It's good to be here. I practiced in Minnesota for about 2 years at Leafline Labs, basically helping patients get to their therapeutic goal in as reasonable period of time with as few side effects as possible.
Okay, so tell me how did you get into the cannabis space?
So pharmacy school really didn't talk much at all about it. The endocannabinoid system was not even mentioned as a major physiological system in pharmacy school, and that's pretty standard in most medical, nursing, and pharmacy schools. Is that it's a major physiological system, but no one really talks about it or teaches about it in their curricula. I ended up practicing primarily in retail environments, independents, and elsewhere, and it was actually my wife that found a position and suggested I apply for it. I'd heard that pharmacists were playing the central role in Minnesota in administering the medical cannabis program, and that's in large part because we don't have DEA numbers, so the federal government can't really target us specifically as practitioners, where they can nurses and doctors. And I didn't know really much of anything when I first got into it. I had an interest in it, but I never knew anything about cannabis before I started. And it was a bit of a surprise. Even when I started, there were no guidelines. There were no dosing or titration schedules. The only theme was start low, go slow, which is reasonable, but there was we were treating it more toxic than Coumadin in terms of how we were dosing. We were treating it like it was chemotherapy level toxicity, and what was happening is that people would drop out because they weren't getting a therapeutic response, and they're spending a lot of money to do that. So I ended up devising sort of a dosing and titration schedule that really paid attention to how patients responded. And right now, that's the dosing and titration schedule I came up with is still what they use for training today.
And is that used nationwide, or is that just strictly used in Minnesota?
Strictly used not only in Minnesota, but only at that one company. Every company tends to practice completely differently. So Minnesota Medical Solutions does it a little differently, and then every state and every probably company within that state tends to do it a little bit differently. Okay. So there is no consistency right now, which I'm a part of an organization called ASCPH, or the American Society of Cannabis Pharmacists, who want to bring some measure of standardization to the U.S. as a whole. And we're working with a lot of different pharmacists from different states like New York, Pennsylvania, Connecticut, Minnesota, and elsewhere, and we want to drop some of those, at least broad standards.
Oh, well, I think the industry really needs that, so I'm kind of excited to see what you guys actually end up debating about and coming up with a result. Now, I met you at the Utah Cannabis Conference. And in one of your talks, and I want to talk about dosing, but I kind of want to give the listeners a little bit overview of the endocannabinoid system as a whole before we get into dosing. And because I know my listeners definitely want to hear about dosing. But you had said in modern medicine, and you just had kind of said that when we're looking and we're studying pharmaceutical drugs, you said that we are really, really good at studying a single molecule, and we can get a result from a single molecule. But when we're looking at like 2 or 3, 4 different molecules or variables in a chemical process, that it kind of gets really hazy of the result that we're getting from a science perspective. But when we're looking at the cannabis plant, we know that there's over 200, 300 different chemical compounds that are in the cannabis plant, and we don't really have a capacity to study that currently, is kind of what you said. So can you kind of expand on that, why that's such a challenge right now in the U.S.?
So in modern medicine, we tend to like single molecule drugs that do one or two very targeted things. And the reason for that is we don't like a lot of side effects. And there's good reason for that. We don't like messy drugs that have one intended effect and 5 different unintended effects. Amitriptyline is a good result, or a good example, where it's originally intended as a tricyclic antidepressant, but it also can cause arrhythmias. It also, if you combine it with alcohol, you can end up dead. It has significant drowsiness and some other issues that are a problem. So in modern medicine, we like targeted single molecule effects. However, it turns out that in most cases, that's a really good way of doing things, but not in all cases. And I think medical cannabis is a good example where the exception that proves the rule, in a sense. And so modern medicine, medical cannabis is not like modern drugs. It's not 1 or 2 chemicals doing 1 or 2 things. It's 200-300 chemicals doing thousands of things, most of which are poorly understood. And like you said, it's hard to study, but there are ways of doing that, probably not using the classic systems that we've used in the past, where we have, we're looking at 1 or 2 small variables in a double-blinded placebo-controlled trial. We're going to have to use much more modern techniques like artificial intelligence to be able to actually measure these sort of things. Israel is actually investing in that level of technology to look at all these 200-300 chemicals and look at patient responses. They're required to actually submit their usage and therapeutic response data as to participate in the program. So by requiring them patients to submit this data and knowing the detailed chemical analysis of every single one of their batches, they can do that analysis much better. And we're going to have to redesign our systems for evaluating results to include a much broader variety of chemicals in a medication. It's a little bit more old school, a little bit more herbal oriented, but there is some value in that because these chemicals that are working at a low level are synergistic. When we choose to treat cannabis like a single molecule drug, it doesn't work very well. Where it works really well in a lot of different things. I would rather take aspirin than chew on a pile of bark, honestly. But that's where a single molecule is doing something relatively targeted that we can control. In cannabis, when we try and treat it like a single molecule drug, like take THC out naked and give it to somebody, it doesn't work as well as a medication to reduce nausea, pain, things of that nature. It actually works much better with its other chemical constituents because they're both regulating it and also magnifying its effects synergistically. So that's where it's not as amenable to single molecule treatment as most other drugs are. Rimonabant, as you had mentioned, I'm probably mispronouncing that was another single molecule target that was an antagonist to what THC did and was designed for weight loss. And it did help people reduce their amount they ate and they had some weight loss. It's just that they wanted to commit suicide. So it caused severe catastrophic depression and suicidal ideation and actual behavior on a really significant level. So by messing with the cannabinoid system in a single molecule, very powerful way is actually incredibly dangerous. We also find that with synthetic cannabinoids, some of these synthetic cannabinoids that are powerfully designed to synthesize or to affect the cannabinoid system even more powerful than the natural endocannabinoids, they're deadly. They're incredibly deadly. And I think these low-level acting effects that are synergistic actually add up to a much better medicine than choosing a single molecule targeted, very powerful approach. It just does, that actually induces toxicity, where this low-level, multiple chemical synergistic approach is much more effective. And we rarely encounter that in medicine, but in the case of cannabis, it's actually the way it plays out.
Okay, so let's break this down just a little bit because I want to talk about the synthetic products that actually have been put on the market. So let's start with Rimonabant, and I don't know if I'm pronouncing that right either, but I know that particular drug for weight loss was used for weight loss in 50 different countries. And I know it did, and like you said, I know that it did get pulled, but it never did come to America. So I want to ask the question, does the FDA do such a good job, that's why the drug didn't come here to America? Just because we have so tight, strict rules and that works in our favor? Or was, what can you kind of, do you know anything about that?
Yes. I think in large part that is one major reason it never came to the United States. It is, the FDA is much more strict in some of its requirements as compared to some other like European markets. It's easier to get a drug passed in those systems as compared to the FDA. So the FDA is more strict. So there is a benefit to that in that regard.
Okay, what about, let's just talk about weight loss. I mean, because that's why it was put on the market. How can cannabis help weight loss from a physiological standpoint?
So there's a couple of different ways, and actually I think they went about it the wrong way, because they found that, so THC in general, when you first start dosing it, before you develop tolerance, causes hyperphagia, or an increase in eating, i.e. the munchies. And you can show that in both mouse and human models, although we don't have clinical trials on that. In the short term, THC generally increases the amount you eat and reduces nausea. However, in the long term, that is not the case. So tolerance rapidly makes that effect go away. So even when it comes up with chemotherapy, where you want that increase in eating, you want that reduction in nausea, the hyperphagia effect is actually temporary. And when it comes down to weight loss in the long run, THC or cannabis, I'm going to refer to this in general, can actually promote weight loss, or essentially better control of glucose, and it tends to be weight neutral in the long run. So when you do rat models in the long term, and you give a population of rats a high fat diet and no cannabis, they get fat. You give the rats a high fat diet and cannabis, and they don't get fat. Why is that? And that's in large part because of the complex set of effects that it's doing in the long term as opposed to the short term. So in the short term, you increase your eating, you may gain a little bit of weight. But in the long term, it's actually changing fat metabolism and glucose metabolism on a significant scale. So for example, THC, and this is getting a little bit into the weeds on the pharmacology, THC is a PPAR alpha and a PPAR gamma activator. And I know that sounds like just letter soup, but we have other drugs that are PPAR. We have another drug that's a PPAR alpha activator. It's called fenofibrates. These drugs are they lower cholesterol, they lower triglycerides, and they reduce heart attack and stroke risk. So we have a category of drugs called PPAR alpha activators, fenofibrates. So we use that a lot in cardiovascular disease and things of that nature. So it actually reduces your triglycerides and reduces your cholesterol and actually lowers heart attack and stroke risk. So THC is doing that. It's a fenofibrate by its activity. It also is a PPAR gamma activator, which does a lot of different things, but one of its core effects is it reduces glucose in the bloodstream. It reduces insulin sensitivity and or insulin resistance, I should say, and it reduces the total amount of insulin you're producing. It actually lowers your A1Cs and your blood glucose substantially, and we have a category of drugs that for that called diazolinodiones, or the glitazones as they're also known. So THC itself is acting as a fenofibrate and a glitazone, actually acting to lower your cholesterol and your glucose, and overall that reduces your metabolic disorder risk. So it can actually improve your glucose numbers, and CBD is also a PPAR gamma activator as well. So CBD, in addition, is lowering your glucose and improving. And PPAR gamma plays a significant role in inflammation as well. So it's having an effect on both glucose metabolism and inflammation. And that's both THC and CBD. So in the long run, your glucose numbers actually get better, your cholesterol numbers get better, and it is weight neutral in the long run, shown in the rat model where you take this and spread this out over a year, it's weight neutral.
So what I'm hearing you say really is cannabis is the next medical revolution. I mean, penicillin changed the trajectory right after World War II in medicine, and we were able to save lives. And from what I'm hearing you say, even just with weight loss and the way that the world, not just America, is suffering from, obesity. If we could actually study this even a little bit more detail in more depth, we could really make a difference in the obesity epidemic.
I think so. And what we feared when we first started practicing, we and our patients who were diabetics were afraid it was going to actually negatively impact their numbers. So we monitored it actually quite closely because of that. And we tended to be more conservative with some of our diabetic patients. However, we would have them turn in their A1Cs and whatnot to us so we could scan it into our system. And the trend that we saw was that diabetic patients were actually doing better. It was having between a 0.5 and 1% improvement in A1Cs, which is equivalent to a modern day anti-diabetic medication like a thiazolidinedione again. And so I think that cannabis could play a significant role, both THC and CBD, but also probably other cannabinoids that are in there that we don't really understand all that well, in reducing metabolic syndrome. So I think it has a significant use there. And when you use it for longer periods of time, any of that hyperphagia tendency fades away pretty rapidly within 4 to 6 weeks. You bring up an interesting point that I know we both wanted to touch on, which was about antibiotics and antimicrobials and what ends up. There's something else that cannabis can teach us as a multi-chemical sort of low-level acting plant, where we choose antibiotics that tend to be very powerful. We use them as single targets to really, like with penicillins, we punch holes into bacterial cells, or with like Levaquin, we screw up their DNA, or azithromycin, we screw up with their protein manufacturing. We target a very singular target, and bacteria rapidly gain resistance to a single target. And we're suffering right now. The CDC has stated that we're essentially at emergency point, like the failure of antibiotics in the United States. We're on the precipice, and we are very much at risk of all of our antimicrobials failing, which would plunge us back to the 1900s in terms of dying of common infections. Where cannabis is very different is it's taken a multimodal approach. Most of the cannabinoids and terpenes are also low-level antimicrobials. They're broad-spectrum, low-level antimicrobials. And we might be able to learn a bit of a lesson in that maybe these super powerful antibiotics that wipe out your gut and give you life-threatening diarrhea isn't always the right answer. Maybe combining a few low-level antibiotics that don't wipe out your guts is a better approach than, say, let's get the big guns out and just use it as a single cannon. Maybe we need to take a shotgun approach, and I think cannabis can teach us low-level antimicrobials that affect fungi, viruses, and bacterium might be a wiser approach than our human let's get the cannons out approach.
No, so you just brought up an interesting point or thoughts for me, because I've studied functional medicine. That's my background, was nursing, and then and then I went into functional medicine. And in functional medicine, we really study a deep dive into the microbiome, and that we have thousands and thousands of gut bacteria. And we've became a country in America anyways, where we're not playing in the dirt. We're not getting into the dirt, and we don't have the good bacteria versus the bad bacteria. And actually, if you were to allow your kids and not use antiseptic, creams all the time, that we would actually have a better microbiome. And we need that good and healthy bad bacteria in our system. And I feel like now there's such a trend, even with probiotics. There's kind of a rage right now because, unfortunately, in the American diet, which is, in my opinion, a really sad diet, is we don't have where we're eating fermented foods, and like kimchi and sauerkraut, and we're also we're just not we're limited ourselves from the bacteria, and I think that is another cause to this. So this is, from what you just said, for me, that just kind of put why another reason why cannabis is so important, because really the basis of disease we're finding is probably 80% in the gut, right? There's a gut-brain connection. There's a gut, you have leaky gut, leaky skin, and we can heal a lot of diseases and reverse a lot of diseases, I should say, by healing the gut and fixing that microbiome. And if cannabis can be an assistant to that, as well as, that's pretty amazing in itself.
And I think I agree. And there are a couple of layers to them. One, another side note is antibiotics make you fat. And there's a reason that we give antibiotics to animals. It's not actually to prevent infections quite as much. Is that when you give antibiotics to animals, they get fat, and they get fat fast. And so the main agricultural use for antibiotics is less about infection and more about getting a fatter product, chicken, cow, whatever, pig, than it is actually affecting infection. Although there is a role of that as well. So it's interesting that actually antibiotics, which wipe out a good portion of the gut, actually drives obesity tremendously, and it's used agriculturally strategically. So that's one thing I want to bring up. And I think when it comes to the guts and the microbiome, I think it's incredibly important. And I think we have, there are a couple hard things to studying it. One, most of the bacteria that we can culture out of the gut, people's guts, are not probably the key players. They're probably less than 1% or 0.1% of the species that are actually important are ones that we can culture up and grow up. The ones that are super important, they don't grow outside of the gut. You can't get them to grow on plates. And so it's very hard to study those bacteria and to isolate them and put them into a probiotic when the best players simply don't survive being turned into a pill. And so that's why you get these issues where they're doing a lot of fecal transplants, because essentially they don't survive out of the gut environment. So you actually have to take the poop, put it into a capsule, and swallow it. And I think that's going to be very difficult, though there is a group that has developed a system for culturing unculturable bacteria in soil bacterium that might be actually translatable to gut bacteria, where we can actually isolate some of these players that we don't know what they are. So when it comes to probiotics, I think there's a lot of misinformation too, where the best guys, we simply can't make into a pill, and we can't study them terribly well because we can't culture them. But I think us wiping out the guts early, or even the increase in cesarean birth, where you don't get the floral, when you pass through the vaginal canal, you get a huge amount of floral bacteria from your mother that is incredibly protective. And if you don't have a vaginal birth, you go through cesarean, you don't get as much of that. And there actually are significant studies that examine that effect in terms of long-term health. So I think it's incredibly important, but we just don't know all the players, and we can't grow them up. And so it's hard to turn them into practical medicine. But I think you're right as well that we are living probably in too sanitary an environment. We're using antibiotics too much. We're using cleansing agents way the heck too much in sort of absurd extreme as compared to, we learned you should wash your hands. Well, you can use soap and water. You don't need antibiotic coated soap. Soap is antibiotic by its very nature. And I think cannabis, as a result though, I think our immune system is I hate to use the word designed, but is evolved with the intent of you're under assault all the time. We were used to be coated in parasites even 100 years ago. And our immune system is used to dealing with that. And when the immune system no longer has to deal with a dozen different infections, it starts attacking itself. And so I think what cannabis does is it's immune modulatory, and it tones down the immune system from overreacting to every perturbation. And I think cannabis's use as an anti-inflammatory for bowel diseases or otherwise is incredibly useful because it modulates the immune system. It doesn't suppress it such that you get sick more if you take cannabis, but it's incredibly useful for modulating our overdriven immune system that is acting in the absence of hostile targets.
Now, that brings me to a different point, actually. So when I started studying cannabis, it was because I was sick for 10 years and suffering from autoimmune disease. I had four different autoimmune diseases. And when I came across this book, the book was called CBD by Leonard Linnau. In his book, he talks about a cannabis index profiling system, and it reviewed 8,000 cannabis studies, and it ranked them on a scale from 0 to 5. And when it did that, autoimmune was 5 being the highest. Autoimmune was, it had 4 stars. And so for me, suffering from an autoimmune disease, I was like, oh, I need to understand this a little bit more. And when you're talking about the immune system, there's so many, I mean, there's over 90 different autoimmune disease. So let's kind of go in a little bit more detail of how cannabis helps the immune system.
So that pharmacology gets a little bit complex, but we can boil it back to, the endocannabinoid system is basically a physiological feedback system that operates in almost every physiological system in mammals. And what it does is it tries to bring things towards a homeostatic point based upon any perturbation. And different phytocannabinoids are doing different things at both directly at the receptors, CB1 and CB2, but also at other targets within the body that are separate. And what THC is doing is it's acting like one of your endocannabinoids, anandamide. So it's mimicking the effects of anandamide directly. It's not as powerful as anandamide. It's about 10% the power of anandamide, but it lasts longer at the receptor. So it's weaker than the natural ligand, but much longer lasting at the receptor. And it affects both CB1 and CB2. CB1 is dominant in the nervous system, but it also exists in the periphery, heavily in organs, as well as on the bone. So like your heart, kidney, liver, all have CB1 receptors, and they play a significant role in organ repair systems. So when you get an injury, CB1 plays a significant role in deciding whether you replace that tissue with scar tissue or whether you replace it with regular tissue. So that rapid healing versus scar tissue formation that's designed to be very rapid and repair things quickly versus like full regeneration, that's governed by the endocannabinoid system, and CB1 and CB2 play a significant role in that. CB2, I'd probably have a question on that.
I do have a question on that, but continue and then I'll go ahead and ask it. So yeah, continue.
CB2 is mostly in the periphery, the rest of your body, and predominantly in the immune system. But it also is present in the brain and pretty much everywhere. THC, like I said, directly mimics the endocannabinoid system, specifically anandamide. And CBD, on the other hand, it doesn't directly. It attaches to CB1 receptor, but it actually causes an allosteric change, which means it shifts its configuration and actually makes it harder for THC to bind, which is why we can use CBD as an antidote to THC or reduce its side effects. But what it's really doing is CBD indirectly inhibits the metabolism of FAAH, or fatty acid amide hydrolase. And that breaks down anandamide and 2-AG. So by inhibiting that enzyme, it increases your endocannabinoid system as a whole indirectly. And so that's what CBD is doing more of, is indirectly affecting it. Its anti-inflammatory effects, it does have some direct effects at CB2, but it has other anti-inflammatory effects that are different, that are separate from its effects at CB1 or CB2. So it gets complicated. Some of these effects are through PPAR gamma. Oh, go on.
Okay, so I want to make this very clear for people. I have a lot of medical listeners, and then I have a lot of non-medical listeners. So I want to kind of make it clear for both parties. Yeah. When we don't necessarily have THC receptors, I want to clarify this. We don't have THC receptors. We have CB1 and CB2. And a lot of people think when we say CBD and THC, because those are the two most common cannabinoids that we discuss in today's culture, right? Because we don't have enough study on the other ones as of yet. So one, I do want to talk about that, but I want to make it very clear that THC is affecting that CB1 receptor and CB2, right? We don't actually have THC receptors.
Correct. We have endocannabinoid receptors, of which THC can also bind, as well as CBG, CBN. A lot of these other ones have structural similarity such that they bind in a similar manner to our endocannabinoids, which are really the natural ligand for CB1 and CB2. So CB1 and CB2 are endocannabinoid receptors that coincidentally also bind to phytocannabinoids like THC, CBD, CBN that are structurally similar to our natural compounds that we produce.
Okay, so now why is the conversation really today just on THC and CBD? Why is the conversation, is it because we just don't have the knowledge on all of the other receptors?
It's mostly that, yes. So we have some physiological knowledge on what CBG does. For example, it plays a role in bone metabolism, as well as what THC it does as well, where it actually seems to increase bone density. So one of the physiological systems that the endocannabinoid system governs is bone breakdown and bone buildup. And you can use phytocannabinoids in order to manipulate that system to create essentially something that increases bone density and osteoporosis. CBG is probably a good example of one that will turn out to be something that in the future will be used for that specific condition. CBN increases the drowsiness, and it probably binds and magnifies the effects of THC. So it's an allosteric binder of CB1, increases the pain effect and increases the drowsiness. And so CBN will be probably more useful in the pain dimension, for example. CBC, cannabichromine, does something slightly different. But we just don't know anywhere near the amount that we do of THC and CBD, and we still know relatively little when it comes to that because you can't study it, especially in humans, in any significant extent. And most of this data comes from animal and cell line data. Basically, for all those other cannabinoids, it's all physiological data that's either cultured cell lines or animals, rats and mice.
I just know this conversations came up with my family because they're like, Jamie, it sounds like CBD, CBD does, and cannabis heals this and heals this. And here they're like, what doesn't it heal? And they were just trying to make fun of me, right? Because they're my family, they can. and I was like, oh, I said, you just don't understand what the endocannabinoid system does in the body. So how do you address that? Because I'm sure I don't have the only family members that are saying it sounds like it's a cure-all. Right. So how do you address that?
And I get their skepticism. And when I came into it, my entire training was around single molecule drugs. And I trusted, generally speaking, herbal medications and things like that were more in this vein. As far I didn't trust them any further than I could throw them. Mm-hmm. And so, but that being said, when you part of the problem is it does, because it affects so many systems, it does sound like a cure-all. And what do we know about cure-alls? They cure nothing. But that being said, nobody teaches about the endocannabinoid system and what it's doing physiologically, even though it's been known since literally 1964. When Raphael McCollum first did his test, and then it's been elaborated on since the 80s. So at least since the 80s, the endocannabinoid system has been well known, well documented, well expressed, yet it's in no curriculum in medical school, pharmacy school, or nursing school. And it is the major homeostatic governing system of mammals. Sorry, I think that's repetitive. So it is the major physiological switch for almost every system in your body. It governs sleep and wake cycles, feeding and rest cycles. It governs mating, it governs neurological excitation, it governs metabolism, it governs bone formation and breakdown, it governs organ repair systems, it governs all these different things, which is why we can use it to sort of manipulate it, all those different effects to some extent. Now, THC and CBD are the ones we know most about, but when you're taking, like, say, whole plant cannabis, it is a whole plant is doing a lot of different things. And that's, and we target specific sort of syndromes, people with inflammatory disease, pain in general, epilepsy that could have multiple different causes. And we can use this one thing to treat all those different things because the endocannabinoid system governs all of those different things. So once you start studying it closely, you're like, oh, so that's why it sounds like a cure-all. but it's really hard to convince somebody with medical training that's used to the single molecule approach that that's worthwhile. And so that's why it has to come to a significant amount of re-education of what is the endocannabinoid system, what is it doing physiologically, and teach that to our doctors and get them to our practitioners and have them understand, oh, this is actually interesting. This, like you said, could essentially be the next burst of medical research, not only in what cannabis and as a plant and extracts can do, but if we study this closely, and Israel realizes this, studying this will lead to the next $1 trillion single molecule targets in the future. So if you want, right now there's almost nothing coming down the pipelines in terms of new drugs, new antibiotics, new anything. It's all Me Too drugs. And if you want to look to the future of modern medical development, the endocannabinoid system is the main homeostatic switch in the body, and it's completely untapped in terms of medicinal potential. So you're right, this will lead to a revolution in medicine, both it is a plant and an extract, but also as single molecule targets that we haven't even thought of yet. So that's why. The endocannabinoid system governs a wide range of physiological functions. Few practitioners know anything about it, and it is sort of like the untapped space for medicine into the next 50 years. So if you want to look to where the next $1 trillion patents are, it's coming from cannabis.
Okay, you mentioned pain when you just spoke just a minute ago, and so many people think that cannabis is a stepping stone to drug abuse or going into drug abuse, just because it's always been taboo. So let's talk about how it affects pain and what it really does, and how it helps with opioid withdrawal.
So both THC and CBD help with pain, though slightly different mechanisms. And I can get into the pharmacology, probably a pharmacology thing that talks about all those that weedy details I can get into a little bit later. It's probably not as useful for all types of pain. Not all types of pain are the same. And so I think cannabis is more useful for certain types of pain than others. For example, for inflammatory pain, I think it works extremely well. So that includes rheumatoid arthritis or other arthritic pains, but also cramping and pain, inflammatory pain in the bowel,
neuropathy,
as well as injury. And then the next area I think is neuropathy. So neuropathic pain is where I think cannabis shines way above any opiates. It is in neuropathic pain. It is much more effective for neuropathic pain than opiates are, hands down. Opiates are actually not terribly useful for neuropathic pain, and they also opiates also sensitize you to pain. So the longer you take opiates, the more and more sensitive to every little pain that comes along you become over time. So you also have to increase your dose relatively rapidly with opiates to maintain the same pain effect. Where with THC, for example, you do not gain tolerance to the pain effect. And they've shown that out to a year, where essentially you can maintain a stable dose without increasing without increasing your dose, and you get the same pain response with cannabis, or with THC specifically. So it's much more useful for inflammatory pain, neuropathic pain, fibromyalgia, some of those harder to treat pains, CRPS, complex regional pain syndrome, things like that. I think it's incredibly useful for, but it has advantages in that you don't gain tolerance to the pain effect. It actually desensitizes you to pain rather than the reverse. Opiates sensitize you to pain. Cannabis desensitizes you to pain, and it's part of the reason it can make it easier to step down on opiates or from opiates once you start medical cannabis. So most of our pain patients would get up to a therapeutic sort of 4 to 6 week point, and then they decrease their opiates from there because it actually desensitized them to pain. It also, via a couple of different mechanisms, reduces the withdrawal effects. And so its desensitization plus its reduction in withdrawal can make it so much easier to step down from opiates than doing it cold turkey or even using things like Suboxone. where you almost become a permanent Suboxone taker once
Mm-hmm.
you start on that, or methadone. I think cannabis is going to be incredibly useful with its desensitization and withdrawal effect or reduction effects to lower opiate doses, and in many cases transition to cannabis chronically in the long run. I think opiates are useful in the short term, not so useful for chronic pain, and definitely not in neuropathy, not in fibromyalgia, and not in inflammatory disease. So I think cannabis will replace opiates in those three major categories.
Now let's talk about your real specialty, which is therapeutic dosing in all of this, because you have a variety of patients that you've helped into getting into that therapeutic endpoint. And right now there's, in the industry as a whole, we're just, there's so many people that are lost, and we're looking for people like yourself to help us find these therapeutic endpoints, depending on the variety of different disease or, abnormality that we have going on in our body. So one, let's just start with oral versus, because there's lots of different types. We have tinctures, we have smoking, we have vaping, we have, suppositories. So in your opinion, is it a combination of those that we use, or how do you start your patients out?
Very commonly it is a combination. But PTSD is different than pain, is different than epilepsy in terms of how we go about treating patients. So I can use those maybe as three generalized categories. For epilepsy, we primarily, where I was, we only had essentially three different ratios. THC dominant with very little CBD, 1-to-1 ratio of THC to CBD, and a 20-to-1 CBD to THC combination. And I'm going to be talking about oral to start with, just because oral is very different than, say, vape or sublingual. It takes longer to kick in, and it's much more potent orally as compared to vape, which is counterintuitive in most cases. You'd think that the vape would be stronger, but it's actually less strong in the long run. With epilepsy, we use the 20-to-1 CBD to THC dominant 20-to-1 ratio. And it was 20 milligrams per milliliter of CBD and 1 milligram per milliliter of THC. And for epilepsy patients, we were using the old GW Pharmaceuticals Epidiolex, some of their study data. And you started between 1 to 5 milligrams per kilogram per day in divided doses, usually 2 to 3 times per day, but up to 4 or 5 times per day for certain conditions. Autism, for example, is a condition where you tended to dose more frequently at a lower dose. And so that's where, like, autism patients tend to be more sensitive to changes, and you'd have to give more round-the-clock dosing, so more like 4 to 5 times per day, where it's more like 3 times per day for the average epilepsy patient.
Now, hold on. Are we talking about adults, or are we talking pediatrics? Because just because a lot of time when I think of autism, I think of younger children. I don't think of the adults that are autistic. And were you treating pediatrics and adults, or
Yes.
we just specifically talking adults?
We treated both. Most of the dosing, though, that is strictly or CBD dominant is pediatric. And the reason for that is because it's so expensive. So the dosing starts around, like I said, 1 to 5 milligrams per kilogram per day in divided doses, and goes up to 25 milligrams per kilogram per day. Now, in a child, you can reach that dose with CBD dominant alone, but the more weight the bigger you are, the much more expensive it becomes. And so that's where we come into the issue, is treating an adult with CBD dominant only for autism or epilepsy is very impractical, because let's dose me. So I'm 100, well, maybe whatever, I'm 185 pounds, so now you all know that. So that is 84 kilograms. And for me to get up to 25 milligrams per kilogram per day, that's 2,100 milligrams of CBD I'd have to be taking a day. Now, the cost of that at where I worked is roughly $5,000 per month. So it's very hard to treat adults with that because it becomes too expensive. So what we would do with adults or larger children is actually get you up more towards 5 milligrams per kilogram per day on the CBD dominant, and then start adding on THC dominant slowly, about 1 milligram, increasing by 1 milligram every 3 to 5 days up to your therapeutic endpoint, i.e. seizure reduction rate or whatever we are treating, behavioral reduction rate. Like if you're autistic and you're having violent outbursts or whatever, we would basically reach a therapeutic endpoint where we have a reduction in behavioral manifestations or seizures. So that's where it gets complicated, is you have to bring in THC because expense gets too high in adults or large children.
Okay, so THC is extremely less expensive than a CBD isolate, or just any CBD. And the reason for that is?
Probably the reason for it is twofold. One, it's harder to extract. It takes a little bit more effort to extract and much more plant material to actually get that same amount of CBD. We've been breeding cannabis for a long time to produce high amounts of THC, and it just produces a larger amount of it. So it's harder to get high producing CBD plants, and you have to use more plant material, and it's a more laborious process. So that's part of it. The second part is there's very few strains out there. I hate to use the word strains, I prefer cultivar, but there's very few cultivars that produce a high amount of CBD. That means the people that own those cultivars can sell it for quite a pretty penny. So you can buy a plant. There's some cases where you have to buy these plants or these seeds. You can spend $100,000 on a plant, for some of these isolates to get, to start your clones and stuff like that. So it's very expensive to obtain some of these cultivars and that might be changing. This is based upon a few years ago. But the major reasons is that it's hard to get those plants, it's expensive to obtain them, and you have to use more plant material, and it's a more laborious process. So it's about 2 to 4 times more expensive than THC.
Okay, and industrial hemp, let's just add that in there right now, because most people, when they're buying their CBD right now, they're saying it's an industrial hemp. And I want to make this really clear to the listeners too. So if I, at the end of the day, if I extract a CBD isolate, if I extract it from any of the marijuana plants, sativa or indica, or if I extract it out of the hemp plant, at the end of the day, if it is a CBD isolate, it's been isolated and it's just CBD. And it doesn't matter exactly what plant it necessarily came from. I want you.
Correct.
Okay. And right now, most industrial hemp, and that's why hemp is being grown and has, from an agricultural standpoint, been, approved across a lot of different states, is because hemp actually has a higher amount of CBD content than the actual marijuana plant. Do you happen to know specifics on that? Because I don't.
I do not. Yeah, I don't know the percentages that are available in different cultivars, hemp and cannabis separately. I think overall it's still relatively low. It's not getting into the 25 to 30% range where you can get THC. So I think still it's higher, natural, on a relative level in hemp, but we're not getting up to, I don't think, anywhere near 25, 30% production. And so that means you still have to use so much more plant material and dump that into the process. And so it still increases the overall expense of it. So I think what needs to be done is some people have to get some mutants that come out that turn out to just produce wild amounts of CBD, or do the genetic groundwork to create those cultivars. But again, once a group or a company controls that, they can control that pretty tightly and still make it very expensive to get those plants.
Okay, let's go back to dosing. That goes back to dosing. That was kind of a little bit of a side point, but just because I wanted people to understand that. So let's go back to the dosing. So for you, that's extremely expensive. $5,000, a month for, obtaining CBD. That's just outrageous. So, yeah.
So for most of that dosing that is CBD dominant, it tended to be pediatric for those reasons, cost being the primary driver. So, but in the optimally, you would want to reach around 25 milligrams per kilogram per day in divided doses, 2-3 times per day. Oral lasts longer than vaporized or sublingual, so it lasts between 8 to 12 hours, and so you dose optimally about 3 times per day for something like CBD. And so for most of our epilepsy patients, that's how we would dose, and it was based upon some of the older data for GW Pharmaceuticals prior to them getting approved. I actually like that dosing better than what they actually got approved. They lowered their dosing for Epidiolex to between 10 and 20 milligrams per kilogram per day, not due to the side effects of CBD, but due to the fact that most of those kids were on other anti-epileptics, and CBD drives up the side effects of those other drugs. That's why they lowered their dose to 10 or 20 milligrams per kilogram per day rather than 25. The 25 is probably more effective.
Was the study so the study wasn't trying to take them off of their other medications, because in clinical practice, ideally, if you said something like that, we'd want to wean them off of some of those pharmaceuticals, correct?
Correct. They weren't trying to do that. In our clinical practice, some patients or parents of patients wanted to do that because the side effects were so high for some of these. I had a patient that with a Chiari malformation, a very severe brain malformation that led to infantile spasms of a really horrible nature. Her side effects on the traditional meds were so horrible that they wanted to get her off of that. And we helped get her to a point of reducing her seizure rate to that of all of the other meds combined with just THC and CBD. But that was their specific choice that they want to do. Most of the time, they want to reduce seizure frequency as much as possible, so they stay on both traditional meds and cannabis most of the time.
This is a real individualized, customized approach to cannabis that you're doing.
Yes.
And I look at other places, around, and they don't have your knowledge, your skill set, and I feel like people are just it's kind of a crapshoot, to be honest, of what they're doing. How, in your opinion, and I know you're building a website that you're trying to help people, and your end goal is to really help individuals trying to find that therapeutic endpoint for them, because there's a lot of individuals out there that don't want to have an impairment or get high. They don't want those side effects. They want the medicinal benefit, of getting their body back into balance. And so tell us about what you're trying, because I know you were going to talk about the dosing, and we were trying to get different dosing on your website. Tell me where you are with that, and what's the end goal.
So with my website specifically, Carruthers Cannabis Consulting, what I try and do is for patients that are interested in reaching that a therapeutic endpoint in a reasonable period of time with as few side effects as possible, including the high effect, but they don't have that medicalized approach in their state. I wanted to be able to provide that to them, and then help them choose medications that are available locally and be able to dose themselves. So what my personal website is designed to do is be a resource for people to come and have a consult with me. I would help you over 4 to 6 weeks or more reach that therapeutic endpoint using local medications and recommendations based upon my clinical practice experience. So that's why my personal website is intended to be a resource as. What the American Society of Cannabis Pharmacists site is intended to be is more of a dosing guideline, clinical practice guideline resource for the nation. So for other practicing pharmacists that are working in Pennsylvania, California, wherever, be able to come and say, okay, what are sort of the general dosing as well as clinical practice guidelines that give you at least a baseline to start from? Because most people are operating in a vacuum. They don't, this is such an area that doesn't have a lot of good double-blinded placebo-controlled trials, and so it's pretty much boiling down to clinical practice locally, and whatever the practice things are locally, and they tend to be pretty haphazard, honestly. What we did at the company I worked for versus what the other company did tend to be very different, and what I hear from other places, again, it tends to be very haphazard. So I want to both help increase some measure of standardization, and that's going to be through ASCPH, but what I may end up doing as a result is posting some of these clinical practice guidelines that are, from my personal experience, on my website as well. So I think that might be useful as rough starting guidelines for patients. But my website is designed to be basically, you come talk with me, you want to use cannabis to help you with pain, PTSD, autism, whatever the case is, and I would help you use local products and get you there. And give you some resources on how to do that step by step.
That's fantastic. I really will be trying to send people your way, because just because I think that your intentions are really correct and true, and I think you can help a lot of people. Here's the confusion, and specifically I've had this confusion. When you're looking at products, you have a CBD isolate. Then I think we need to define the difference between a CBD isolate and a full spectrum CBD. So let's start there, and then I'll ask my other questions.
So a CBD isolate is like you say, it could be from hemp, it could be from cannabis sativa, whatever it's from. It's an isolate that we've taken the CBD portion out and we've isolated everything else away from it, and so it's CBD alone. The other ones, when you get into the idea of extracts, the extracts go along a significant spectrum, and many are calling things full spectrum extracts that are not full spectrum extracts. So there are 4 or so major extraction systems. One is the hydrocarbon, so butane, et cetera, supercritical CO2, ethanol, and as a subcategory, cold ethanol, which is negative 20 degree ethanol, and then there's freon extraction. All of those extract very different amounts of chemicals from the plant, and they're not entirely honest to the actual chemical makeup of the plant. So hydrocarbon is very specific and leaves out most terpenes, many terpenes. Also, the process involving heat damages a good portion of them anyways, so you can't really get a full spectrum extract with hydrocarbon. Supercritical CO2 is also extremely selective, and it hyperconcentrates some terpenes and leaves out other terpenes entirely. So it can make some terpenes show that are in the extract at 5, 20, 30 times the amount that they are in the natural plant. And then other ones, it's 0. So you can't really get an honest full spectrum extract from supercritical CO2 either. Many people claim to, they can't. It's just it's a physics problem. Ethanol and cold ethanol are probably some of the most honest full spectrum extracts, because it gets most of the interesting biomolecules, the terpenes and flavonoids, and also has relatively little post-processing. So it's actually, in the long run, probably less expensive. So if you want a more honest full spectrum extract, you have to be talking about ethanol, or in this case, Freon. I know it sounds scary, but Freon 134A is actually the best probably in extracting the interesting biomolecules, all the flavonoids, cannabinoids, and terpenes in the ratios present in the plant than any other technique. So Freon is probably, and it's very little used in the industry right now. I think it will eventually become the industry standard in 5-10 years, but right now Freon probably is a top for giving the most honest to the plant extract, and then ethanol and cold ethanol are a second, and then supercritical CO2 and hydrocarbon are distant thirds and fourths. So it's very hard to create a whole plant extract. Even though many claim to do it, most of them do not. So that's one side of it. It's hard to do. It's a non-trivial physics problem and chemistry problem.
Okay, but even from a science perspective, so the CBD isolate we know that works. That's what the studies are on, and we know that there's a synergistic effect, an entourage effect with these full spectrums. But right now, from what I'm hearing from you, we just don't have an ideal way to really even define what full spectrum is.
Or assess it. Yeah.
Yeah. Okay.
So that's for the future, I think, is full spectrum extracts and whatnot are more of a future thing than in 5-10 years we'll have a better handle on once we learn about what are those other terpenes and endocannabinoids doing synergistically.
Mm-hmm.
But until we can actually measure them, and then we have standards by which we can measure them, and the US, essentially no company has the standards for most of those cannabinoids and terpenes. They're also very hard to keep in solution because they're volatiles. They tend to come out of solution and they get damaged by heat, water, and light. So keeping them honest to what's in the plant is actually very difficult to do, and we don't know what they're doing in the long run anyways. So 5-10 years, that's probably going to be a much more interesting question. And for right now, we can still use CBD as either sort of a whole plant extract or as an isolate and still get benefit from it.
Okay, great. That's wonderful information. Now let's talk about these ratios. You go to a dispensary and they have a 1-to-1 ratio, a 4-to-1 ratio, but the ratios are not the same. As we talked a little bit earlier, it depends on, well, how many milligrams is in that 1-to-1 ratio. Is there a standard?
There is no standard. There is no standard, unfortunately. And most products are going to have, look at the number of milligrams that are on, like, a milligram per mil or a milligram per bottle, and then divide it out to know how many milligrams am I getting per drop or per, theoretically per puff or per milliliter that I take orally. It gets a little bit, so we can talk a little bit about, maybe we should divide into like THC versus CBD, and then in combination when it comes to pain, just like a single sort of category, since pain tends to be fairly universal. So the way we tended not to use CBD alone for pain. That being said, we did sometimes, but it was relatively rare because of both expense, and it tended not to be as effective as compared to in combination with some measurable ratio of THC. So I think CBD has some significant potential alone, but I think it is dramatically increased by with some measure of THC. Now THC is impairing, so and CBD actually counteracts that impairing effect. So we used it in practice very much to reduce the side effects of THC. Probably my favorite ratio to use, and we had a very small spread. We had THC dominant, 1-to-1, and 20-to-1. That's it. Now, other companies have much wider spreads that can be useful, but 1-to-1 was very useful for treating pain. So oral dosing, so like an oral suspension for pain was 5 milligrams of THC and CBD per milliliter, what we used. So every milliliter had 5 milligrams of each. And where we would start patients orally for, say, pain, was around 2 to 2.5 milligrams per dose, 2 to 3 times per day. And we would then increase by between around 2.5 milligrams every 3 to 5 days, which is 3 to 5 days is the steady state for cannabis in your bloodstream. That means once you're taking a dose steadily at the same dose for 3 to 5 days, your blood levels are now steady at the 3 to 5 day mark. So that's why we chose that. We also, that just seemed to work out for our patients, where if you increased it every day, it was too fast. And if you, but about 2.5 milligrams every 3 to 5 days worked out for the average patient. Sometimes you had to go faster, sometimes you had to go slower. And increase that to therapeutic effect. So patients would basically, I would give them a sheet, and they would record their pain score beforehand, before dosing, and then at an hour and a half later, they would record their new pain score. If it wasn't sufficient, they would continue to take that same dose for 3 to 5 days, but it's, at say the 3-day mark, they would then increase that dose from, let's say we start at 2.5 milligrams of THC and CBD. They would increase that then to 5 milligrams per dose of THC and CBD. So they'd start out at 2.5 milligrams 3 times per day, and at the 3-day mark, they would increase to 5 milligrams 3 times per day, then to 7.5, then basically up to then to 10, 12.5. That's how we would step it up. For the average patient, probably 7.5. It didn't take terribly long, so around 7.5 milligrams to 12.5 milligrams 3 times per day was fairly common for the average pain patient to sort of reach a therapeutic endpoint. Some people were higher, some people were lower on that, but that's in a few weeks, basically, you get to a point where you're feeling a lot better. And we would have patients choose a pain score. Say if they were at a 9 and a pain score of 3 would have been acceptable, that's when they would sort of stop. And then we would fine tune after that. So that would be their.
Now, would these patients take opioids? How would they rate their pain until the cannabis kicked in? Would you give them any type of, I don't know, ibuprofen, aspirin, Toradol? I don't know. Would you give them anything else?
At first, we tell them not to change their opiate dosing, and then they would just, and they would actually, what we would tell them to is typically try and get it so it's separate enough that you could make a distinction between the cannabis kicking in and the opiate kicking in. So if you're dosing your opiate 3 or 4 times per day, make it distant enough that you can recognize, that this is the cannabis that's kicking in, and we're not masking it with the opiate kicking in at the same time. Yeah. That can be a little bit hard to coordinate, but we wouldn't tell them to decrease their opiate doses until they reach the 4 to 6 week mark, because cannabis makes it easier to step down. We tended to advise them to wait till they reach about the 4 to 6 week mark and then start stepping down by a 25% reduction in opiate dose per week down to as close to 0 as they could get.
Now, are these people, okay, so for pain, I guess in your opinion, is cannabis something that they're going to have to continue every day the rest of their life?
It depends. I think for some people that have like a chronic disease that's semi-permanent, like they have a neuropathy that is induced from an injury, or they have a rheumatoid disease that's going to exist for the rest of their lives, yeah, they're going to have to take it probably for the rest of their lives. For those people that are, I think they can also use it in the short term. Another example of how like pain can be a bit of a thing, because a lot of these people are taking it pain medication chronically, regardless, and they whether it's ibuprofen, whether it's opiates, whatever. So cannabis, I think most people that are taking it for pain are probably going to take it in the long term. But I think it's safer in the long term as compared to opiates, in that it can't kill you. But for things like PTSD, it was a little bit different. So where we tended to combine a long-acting oral and a fast-acting either sublingual or vape for pain, where they can use the oral as your baseline and then the vape or the sublingual to fill in the blanks when it's either wearing off or before it kicks in. That's how we would treat pain, is long-acting oral, short-acting vape. PTSD, on the other hand, people tended not to use the oral very much, and they wanted something that acts fast to help stop a panic attack. Yeah. So for those individuals, the oral is more used for sleep and reducing night terrors, and the vape more for anti-anxiety periodically throughout the day. So PTSD tend to be very, very the reverse of what pain was. Pain used a long-acting oral as its meaty base, where fast-acting is much more useful in PTSD, things that come on rapidly, like panic attacks and things like that. For epilepsy, long-term is almost definite. For bowel disease, that tends to be more cyclical. So for a lot of patients, I think they would probably take that in a phased fashion, where during times when they would have flares, they would take it much more. People with eczema again, or something like that, that are much more flare dependent, would probably only take it for that 3-month period where it's really bad.
Okay. What about, because I know this question comes up all the time, vape and cigarettes, inhalation. We've been told for so long, smoking is so bad for you, and now vaping's came along. What's your thoughts on what that does to the lungs?
So cannabis effects on lungs are different than cigarettes for a couple of different reasons. One, there are natural bronchodilators, alpha pinene, that are in cannabis that probably reduce some of the constrictive effects that happen with long-term smoking. We also, there are studies that evaluate people that have smoked cannabis all their life and people have smoked tobacco all their lives, and their cancer risk and emphysema, COPD risk. And the patients that smoked cannabis do not have an increased risk of COPD, emphysema, or cancer above baseline population. And that's probably due to a number of protective effects that are going on. These are due to some of the anti-cancer effects and the anti-inflammatory effects that exist in cannabis, and that even though you're smoking something and creating the same combustible products, the polycyclic aromatic hydrocarbons that are so bad that cause inflammation and cancer, in both cases, it's just that the anti-inflammatory and anti-cancer effects of cannabis in the long run reduce your overall cancer rate to baseline, where it does not with tobacco at all. So there are some risks with smoking cannabis. I think it's better to vaporize it because you're not creating those polycyclic aromatic hydrocarbons that are inherent to combustion. However, I think it is safer to smoke cannabis than it is to smoke tobacco or any other plant product. But most states and whatnot, their programs want you to go towards vaporizing. It's lower temperature. You're still vaporizing. Essentially, you're getting to a high enough temperature to release those compounds and decarboxylate them, but you're not getting to a high enough temperature for combustion to create those really nasty products that cause cancer. And so I think it's probably better to vaporize, but it's better to vaporize overall.
Does it matter what the vape is made out of? Propylene glycol, vegetable glycerin? Does it matter what the vape is made from?
Probably. Now, the evidence is still a little bit out. Using, most of these products are done in like a 70-30 propylene glycol, vegetable glycerin combination. Some of them are done with, some of these vapes are done with MCT or medium chain triglyceride. I think that's a really bad idea. That actually has been shown to cause oil-induced pneumonia. So MCT based, and there are a number of companies that are very specifically thin the oils, the vape oils with MCT, and I think that's a really bad idea. That has a strong correlation with oil-induced pneumonia, where it disrupts the alveoli, the surfactant, and causes these deep pneumonias that are very hard to treat. But the problem is all the cannabis oils are extremely thick. So most of the old systems that are designed to vaporize nicotine, well, it's just so much more thick. And most of those systems were designed to deal with a 70-30 propylene glycol vegetable glycerin mix. And so people are trying to use old technology to use cannabis. And I think what's coming along now are better vaporizing systems that are designed to handle a thick oil. And those are probably what I would choose rather than a diluted system that either uses MCT or propylene glycol and vegetable glycerin. And some of those probably have a long-term potential problem, but we don't know what they are. And we'll probably only find out in 20 years. Also, the heating elements, there are some concerns about using heating elements that can release some of these metal ions and cause some problems with that. I think there are some significant concerns there, and we should probably be choosing elements that don't have the potential to leach out metal ions in high concentration while you're vaporizing it, because heavy metals and your body aren't terribly well compatible. So I think new technology that eliminates heavy metal production and is able to use thick oils without dilution is probably the best choice.
We didn't talk about this, but I know a lot of people use cannabis for their animals. Is the dosing different for animals?
we're getting outside my wheelhouse a little bit,
Okay.
but I think the answer is yes. But I think where cannabis is going to be especially useful in animals, one is anxiety. You know, some of those little things like I think CBD and things like that are going to be useful for anxiety. But where I think it's going to be especially useful is most animals, most pets, can't take NSAIDs like humans can. They cause acute renal failure in most animals, including humans. And we really don't talk about the effects of NSAIDs and acute renal failure in humans a lot, but it's pretty high.
Mm-hmm.
So NSAIDs cause several major problems: increases heart attack and stroke risk, bleed risk, thins your blood, can cause birth defects, and then cause acute renal failure. It's the acute renal failure problem that makes it so that animals don't have a good NSAID available for pain. Now, cannabis stands in a really good position to be the NSAID for animals, where they can take it, and I don't know what the exact dosing is and I think it's going to vary from horses to cats to dogs. And vets are going to be really the resource for developing those dosing ranges. But I think because it doesn't induce acute renal failure, it is going to be the choice eventually for pain and inflammation in animals.
Okay. And the reason that I asked, I'm bringing a vet on to specifically talk about that, but I just wanted to get your perspective before I brought the veterinarian on. So that's why I did that. Okay, so dosing, you told us how to find us. Is there anything else that we would need to know that you haven't discussed about dosing? I think you've done a really thorough job, but.
So that's mainly for oral. The way we help patients reach a therapeutic endpoint for like sublingual or vaporized, where it's a little bit less exact because every puff is a little bit different, that sort of thing, is we would have patients start with record their pain score before they would have a puff. They would have a puff, wait 10 to 15 minutes, and it's about 10 to 15 minutes for peak effect. And if their pain score was not lowered enough, they would have a second puff at that 10 to 15 minute mark. And then when they had their next dose in 4 to 6 hours from there, they'd start with 2 puffs. And they wait 10 to 15 minutes. If that pain response was insufficient, they'd have a third puff at that 10 to 15 minute mark. And then 4 to 6 hours later, they'd start with 3 puffs. So it's more rapid. You can dose the sublingual or the vaporized more rapidly than oral. Oral, you have to be very slow and careful with because it's 4 to 6 times stronger and it's really easy to overdo. So you can dose sublingual and vaporize much more rapidly. And in a few days, reach more of a therapeutic endpoint where it takes closer to 4 weeks with oral.
I want to clarify that when you say oral, you mean edibles, and when you're saying sublingual, you're just meaning the tinctures that you take.
Tinctures drops that go into either under your tongue or in the buccal pouch of your cheek. Oral can refer to edibles, or what we specifically used was a solution with a very specific concentration. But edibles could be substituted as well.
Okay.
Yeah.
And the onset on the edibles and anything orally is delayed because the GI tract has to assimilate it. So
both has to absorb it, which has a delayed response, but it also gets then heavily processed through the liver, which further delays that response. You absorb maybe 20% of what you take in orally. So if you take it in on average, where you absorb about 25 to 30% vaporized and probably 10 to 15% sublingual. So you're absorbing not 100% of whatever dose you take. About 20% is what you absorb orally. And it takes a while to absorb, and actually taking it with a fatty and proteinaceous meal makes it absorb better and more consistently, especially if you're taking a capsule or very concentrated version of it. So take it with a fatty meal is one thing I always pointed out with patients, like whole milk or something like it, in order to help break it up into absorbable bubbles. So absorption takes a little while, and then it gets processed through the liver, and THC, for example, gets turned heavily into 11-hydroxy-THC, which is where it's 4 to 6 times stronger. And that liver processing actually takes time for it to build up in your bloodstream. So that adds an overall delay of about an hour and a half on average.
And it
45.
becomes stronger. That's interesting that it becomes stronger. And that's why edibles, really, really need to wait till that kicks in to see the effect. And that's why some people like that, because they like the high, and that's why they prefer the edibles, correct?
That's why sometimes I prefer the edibles. It's a very, people sense it also differently. So it doesn't build up as heavily in the brain. So when you take vaporize something, it builds up in the brain extremely rapidly. So it feels very different than something that builds up more slowly and leaks out into your body and your brain differently. So it distributes very differently when you take it orally as compared to when you take it sublingual or vaporized. So it's a more rapid effect that you get in the brain that redistributes to your body, where it's almost the reverse. It builds up in your liver and then your bloodstream and then concentrates in your brain almost second, and then redistributes further from there. So people sense it very differently. I think people like it because it tends to be more intense and longer lasting from a high perspective. But from a medicinal perspective, it's useful because it just lasts so much longer, and you can use it to give your baseline. That's what we primarily used it as, is we can give you a long-acting baseline at a lower dose. A lot of people, 2.5, 5 milligrams, maybe where they end up for their dose. And then they use the vape to just fill in the blanks when that wears off a little bit. So it's very useful for just the long-acting effect.
That's, there is a lot to know with cannabis. There's a ton to know to cannabis. And so to wrap this up, I want to say thank you for sharing all of your knowledge. And also, I know that you've done a lot to help legislation in a variety of different states. So thank you for your work there. And that probably is a whole different podcast that we probably need to do just on legislation. So, but I want to thank you for that. And again, I want you to leave with the last note of how people can find you and what your website is. And I definitely will be sending people your direction.
Appreciate you having me on the podcast, and I really found it valuable to meet you at the Utah Cannabis Conference. My website is Carruthers, www.carruthers, CARRUTHERS, Cannabis, CANNABIS, all one word, .com. So CarruthersCannabis.com. And what I try and do there is, again, help patients reach that point, therapeutic endpoint, using whatever they have available locally. And eventually I'll probably put on dosing information and guidelines for people just to be able to have, as not make it mysterious anymore.
Well, great. As soon as you have those, I'll be putting those on my website as well. So, and referencing your name and sending people your direction. So thanks so much, and appreciate it. And look forward to the next podcast with Legends, Health, Wellness, and Performance. Thanks again.